هاي الندوة إقامت بالتعاون. الندوات اللي تعودنا عليها في الكليات قيمة مسابقة جيدة تعاون بين كلية الطب جامعة الموصل وكلية الطب الأسنان، وإن شاء الله نكرر في مسابقة الندوات الأخرى. الجلسة الثانية فيها المحاضرة الأولى بالجلسة اللي هي الخامسة في تسلسل محاضرة تكون مقدم من قبل الأستاذ الدكتور راجح الخطيب. واعتقد الدكتور راجح هو شخصية غني عن التعريف، هو رئيس فرع الأطفال والتقويم وطب الأسنان الوقائي، خريج كلية طب الأسنان 1992، شهادة الماجستير جامعة الموصل 1998، وشهادة الدكتوراه من جامعة العلوم الماليزية 2011، ولقب الأستاذية الدكتور في عام 2020. أستاذ الدكتور علي راح يقدم محاضرة حول Orthodontic protocol in the treatment of cleft palate patients. Dr. Ali, you have 15 minutes for your
Thank you very much for giving me this opportunity to participate in this lovely discussion. Actually, we can say that the orthodontic intervention represents something needs or something second step should be conducted after the intervention by surgical or prosthetic ways. This important developmental stages should be run, of course, in accompanied within the other bodies. Actually, the major problem that could be met after the prosthodontic surgical intervention is what will happen in the growth of the face. Generally, the growth studies have been said that the maxilla is going to get in the patients with cleft and palate variable degree of maxillary hypoplasia. Means that the maxilla is going to drop back. We are going to get something called dish face in such a condition. The reason behind the abnormal facial morphology in cleft patients may involve different factors, actually the intrinsic skeletal and soft tissue deficiency, iatrogenic factors introduced by the treatment, and of course the combination between both of them. Accord the cleft lip and palate deformities actually are very in similarities. In some patients, they may be varied amount of missing tissues such as bone, soft tissue, teeth associated with non-fusion of the cleft segment. Moreover, there is some inadequate tissue volume. However, the cleft segments cannot be or fail to be work together or fuse together. Orthodontic problems means the problems within the dentitions in late and early mixed dentition result from the effect of previous procedures. The closure of the lip creates some constriction of the alveolar part of the maxillary arch, and closure of cleft palate causes this degree of lateral constriction, maxillary constriction in this case. I know that the surgery is something necessary for aesthetic and functional reason. However, the orthodontics here must be considered as a necessary part for the rehabilitation, because everybody knows that the patient seeking for the appearance and also the function. The teeth is something extremely important and representative in the function of the oral cavity. Orthodontic treatment generally could be involved at infancy before the initial surgical repair, as my colleague have been talking about, during late or primary and early mixed dentition, during the late mixed dentition and early permanent dentition, and of course at late teens after completion of facial growth. Orthodontic intervention, it looks like unnecessarily important at the primary dentition. until the permanent incisors erupt. In this case, it is important to think within the arrangement of the teeth, because this is going to help in the further steps of intervention. In addition to that, when the permanent teeth come in, there is a strong tendency for the maxillary incisors to be rotated, and the crossbite is going to be happening, as has been presented in the images here. We can see an irregularities of the teeth, and then we can see in down the crossbite. The crossbite has been presented in the X-ray. There is an opposite relation between the maxilla and mandible. The major goal here of orthodontic treatment is then to correct the incisors position and then prepare the patient for what we can call the alveolar bone grafting. Alveolar bone grafting. Actually, the objective is to have permanent teeth erupt through the graft, through the area of graft, as being presented in the image. Because sometimes we get teeth nearby the area of grafting. We want each tooth to come in the oral cavity and within the dental arch. We don't want to run behind the prosthesis within this area. As far as the teeth are available, so we can run behind this. The major concern of the alveolar bone grafting is to what we can call give away or make a split for the teeth to move within and then come within the line of the dental arch. As I said since before, in primary dentition, the major intervention that could be happening is just to improvement of the speech and function of the child rather than seeking behind the orthodontic treatment. However, after that, we should search behind the monitoring of the eruption of the teeth, which is important at the age of 6 to 7 years. Radiographic evaluation is needed at the age of 8 to 9 years after eruption of upper incisors to detect any possible tooth position in the cleft area, and to see if the lateral incisor is missing or not. Lateral incisor is missing or not. Lateral incisor is usually come at the area of defect. In such a case, if I cannot bring it to the dental arch, here I should think or I should decide to remove this tooth. However, if it lies in between, or what we can call in the sides of the suture bone, tooth movement, as I said since before, should be conducted on the time and not to be delayed till I can get the bone grafting. I have 2 steps: pre-grafting, post-grafting. Pre-grafting, what's the things that I can do pre-grafting? At age of 7-9 years, incisors alignment, correction of a crossbite can be provided to maximize the forward development of maxillary dental-alveolar process before the graft. Here, as I said since before, I get some kind of expansion, what we can call the crossbite, constriction, reduction in the size of the maxilla. In that case, I should expand the maxilla first, expand it in horizontal direction. In such a case, the expansion could be accompanied by the alignment of the teeth on the same time. It means that I would like to arrange the teeth and also correct the crossbite in such a condition before starting the operation for the alveolar bone graft. If possible, the transverse expansion can be combined, as I said since before, with the correction of incisors irregularities. Arch expansion is very important procedures, so as I can correct the morphology of the dental arch and facilitate the next steps. Different types of implants actually available to get the expansion of the dental arch, different techniques. We have the rapid maxillary expansion, slow maxillary expansion, dependence on the condition of the patient, decision of the orthodontist, who would like to run within this. And after that, we try to maximize the effect on dental position and maximize the skeletal and alveolar expansion to the highest level that we are searching behind. After finishing of the expansion, we should know that the relapse tendency is very high in such a patient. In that case, I need to fix my expansion. This fixation could be conducted with a transpalatal arch, which is used to prevent any transverse movement that could be happening after the expansion. This something very easily to be constructed, could be inserted in primary teeth, as you have been seen in this image, or you can put it in permanent, nothing wrong there, as far as you are going to keep the space that you get it as it is. Then, the second step is going to be the alveolar bone grafting. Alveolar bone grafting. There are a major principal benefits for this grafting, which provides sufficient bone for the eruption of the either maxillary lateral incisor, if present, or the canine, providing adequate bone and soft tissue coverage around the teeth adjacent to the left sides, closure of oronasal fistula if available, and also escape the fluid that prevents escaping of a fluid or fluids to the what we can call nasal cavity. Provide additional support and evaluation to the nasal structures, and so on. All of these considered as major benefits for the simple bone grafting at the area of the maxilla. Different steps of bone graftings are there, starting from the primary, early secondary bone grafting, conventional secondary bone grafting, and late secondary bone grafting. All of these dependence, as assessments before, patient condition, presence of lateral incisors, canine, steps of expansion, and so on. Timing of a graft is primarily dependent on status, again, maxillary lateral incisors, which is lies at the area of the fusion, if present, and also depends on the maxillary canine. If the lateral incisor is present, it's preferable to perform the alveolar bone graft prior to its eruption. It means I am going to guide this tooth to be erupted in the oral cavity. If the lateral incisor is absent, bone graft should be performed before the eruption of maxillary canine when the root is half to 2/3 formed. Of course, this could be detected very easily within the panoramic X-ray. An eruption of the tooth brings with it creating a new bone beyond the limit of the previous graft. If the permanent lateral incisor is present, the graft should be placed in about 7 years of age before the eruption. If the lateral are missing, the graft can be delayed but should be done before the permanent canine to be erupted. Any necessary alignment of the incisors, expansion in the posterior region should be completed before the grafting. Orthodontic tooth movement of a cleft adjacent teeth in the direction of a graft bone can be instituted at the average of 3 months after bone grafting, if needed, and combine intercepted bone grafting and orthodontic treatment at early age. Avoid more extensive and prolonged treatment later in patient life. Here I need to stop within this point. It has been recommended not to delay orthodontic treatment more than 6 months after grafting in cases in which should crosswise or residual transverse posterior crosswise exist. This is what we are thinking behind. As far as we are going to move the tooth or teeth earlier, we can get a better response than the delaying of procedures. We are searching because you know that the intervention within the patient with cleft and palate from orthodontic point of view cannot be finished within what we can call limited time. The usual time for orthodontic treatment is from 1 year to 1.5, maybe 2 years. However, within the patient with the cleft and palate, extended time. I maybe need 5 years or maybe more, depends on patient condition, because as I'm going to explain later on, it is not the end of the story at the mixed dentition. The story here is in its halfway. The first being conducted surgically and within the prosthodontic appliance, then orthodontic treatment come back to rearrange what I have from the teeth. Then after that, I need to keep continuing till the 18th of the age. Some of the authors stated that till the growth completion or till the growth stop. And this is actually, I think this is a major or fatal mistake. I cannot say the growth stopping. The growth of a human stop only when we die. There is a change in the growth. Maybe the level or the rate of the growth is going to be reduced in some way. However, there is still some kind of change, although the changes may be not significant or not clear, but it was a growth in this region. I should give it at one. After the post-grafting procedures, I should start or continue within the rearrangement procedures of my teeth. As I have mentioned, within this case, actually the lateral incisor have been removed from the area of fusion, and the author tried to bring the canine at the area of fusion after creation of the alveolar bone grafting. And of course, we can see here the fixer, if I want to say fixer, in another word we call it retainer, which retain the corrected crossbite. These are some cases I would like to share with you. Actually, we can see here the area of defect. Here we have the region of the canine. Sometimes very difficult to bring the canine within this fusion line unless we have a bone that guide the tooth to be moved within. And then after that, the steps of construction keep continued after that closure of the flap, and then creation of necessary space, expansion of the dental arch, and so on. Not easy to get all these steps till we can rearrange the dental arch in an acceptable manner. Again, these are some cases which represent the expansion of the dental arch, by the different procedures that I have been experienced before. This is not the end. As I said since before, this is the midway. Later on, I have to think about what I need to do. Depending on severity of the malocclusion that's being presented by the cleft patient, the management can be actually categorized into 3 main lines. If there is no skeletal discrepancies and orthodontic correction is limited to tooth movement only, this is the first step. If the patient has mild skeletal discrepancies and will benefit from camouflaging of orthodontics by orthodontic tooth movement, camouflaging means I am going to arrange the tooth, but keep the maxilla as it is. In that case, if I have severe malocclusion, no In that case, I have to shift what we can call the orthodontic surgery. In this case, I need to change the position of the maxilla, reshift everything, in accompanied with orthodontic intervention to keep the arrangement of the teeth as they are, and then rearrange also the skeletal structure of the patient. Sometimes when there is no way to restore the tooth, its normal position, no way to return it within the normal configuration, I have to think within the prosthesis, such as implant, dentures, and so on, to restore the normal functional appearance of the teeth. This is some of the conditions that is severe, that has a severe problem in the maxilla as being presented within the X-ray. Of course, the orthodontic intervention in this case should be conducted at late teens of the participant when the growth of the maxilla and mandible takes steady level of change or insignificant level of change. Generally, in regards to, or from orthodontic point of view, we cannot do all of these things alone. We are just a part of this system. We can conduct some kind of arrangement within the dental arch, teeth, bone. However, we are still thinking that the teamwork is the most important way to get the maximum or optimal result for the participant. Thank you very much.
السلام عليكم. تفضل الدكتور ياسر أحمد العطية لإلقاء محاضرته بعنوان بلاستيك راينوبلاستي